What's up, guys? It's Dr. Tim Jackson with another episode of the Boss Body Podcast. Today, we are going to talk about long haul COVID. A lot of people have it. If you haven't had it, you probably have a friend or a colleague or a family member or a loved one who's experienced it, and maybe you want to help, but you're unsure how to help. So, I brought in an expert, Dr. Keith Ellis, who's a professor of medicinal chemistry and a formulator of pharmaceutical grade nutraceuticals.
While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
Welcome to the show, Dr. Ellis.
Hi, thanks for having me.
Absolutely. So what got you interested in this topic?
So I'm an academic, right? I'm a scientist, I'm a professor, I'm a medicinal chemist by training. Medicinal chemists are kind of that subset of chemists that do drug discovery, right? So that's kind of the space I've always worked in my career, and I've worked in kind of the earlier stages of drug discovery. It's always been what interested me. So what I like doing when I want to start a new project is I go into the literature and I pick a disease state. I've worked a lot in oncology. I've also worked on antibacterials, and I'll go into an aspect of a disease state and I want to find what we call new molecular targets. So new proteins that we can develop drugs against. And I start that early process of finding new molecules that can help modulate a molecular target and start that process of drug discovery and development. That's kind of what I like to do. So in early 2023, I decided that I wanted to really start looking at long COVID. You know, COVID had been around for a couple years. Acute COVID infections, we kind of had a handle on at that point. And in general, we know and understand how to deal with acute viral infections. But in early 2023, long COVID had really started to gain some momentum. More people were suffering from it. And just from a cursory look, there wasn't a lot to do about it in terms of really helping patients. So I wanted to go and see what we could start doing for early drug discovery in the long COVID space. So I went into the literature really intending to start kind of a normal academic project for my lab. And based on what was in the literature, I ended up taking a completely different approach and doing something very different that drew more on my natural products background and training from earlier in my career.
Absolutely. And did you have personal experience with long COVID?
I have not had long COVID. I had a good friend that had it about the time that I was starting this. And what I kind of observed was that my friend, he went to the doctor. He was trying to get help. He had really bad fatigue and the brain fog, some of the cardiac issues and the respiratory issues, the shortness of breath that come with long COVID. And he had a real hard time getting any help. He went to his primary care, got past the specialist, got passed from specialist to specialist, and nobody was really helping him. And there weren't any treatments, any therapies, anything even over the counter to help people with long COVID. He came to me and he because he knew I worked in a school of pharmacy and I'm a scientist. He's like, what's up with this, that there's nothing to help people? And that's when I really started taking a hard look at that and decided that was something I wanted to actually do.
Absolutely. And so there's a couple components, right? There's the spike protein issue.
Mhm.
There's
Yep,
the cytokine storm, which may,
yep,
cytokines are kind of self-perpetuating, right? Like interleukin-6, TNF alpha.
yep.
And then there's the microbial mitochondriopathy. So when we get a pathogen, it's not just COVID, any pathogen. A lot of times traditional medicine assumes that that pathogen just goes away, but the way we silence its expression is through the methylation cycle. We methylate those CpG islands. So talk to us about the different components of what constitutes long haul COVID.
So I'm most used to talking about it kind of in terms of symptoms and then in terms of kind of molecular mechanisms. And I think of them right now in an ideal world, we connect the two, right? And we have an overall picture. And right now in long COVID, we're still kind of we see them as separately, right? You talk to patients, you look at patients, they have an array of symptoms. And when I look at the symptoms, kind of what I see from my point of view is there's these core symptoms that just about everybody with long COVID seems to have. And then there's this larger constellation that's more variable, where people will get some but not all. And this is where
Right.
long COVID gets to be a difficult disease because it's almost heterogeneous, even within its own population, because people's symptoms don't ever 100% match. So those
Right.
core symptoms are that shortness of breath and the brain fog, and there's usually some kind of cardiac disruption or respiratory disruption, like tachycardia or irregular heartbeat and kind of shortness of breath. To me, those are kind of the core symptoms. And then once you get into the larger constellation, you really start crossing into every physiological symptom in the body, right? There can be more advanced cardiovascular effects. That's when you start getting into the POTS. There's dysautonomia and dysregulation of the autonomic nervous system. There's the muscle pain and joint pain and neuropathy that comes with it. The CNS effects that go beyond the brain fog, bad headaches, and even depression and anxiety that come with it. Obviously, the immune effects as well, and even into a lot of long COVID patients experience gut dysbiosis and really upset of the GI system, and to the point where between that and the immune response, they can often end up with MCAS as well, or mast cell activation syndrome. So that's kind of the way I see the symptoms. I would be interested to see what else you would add to that from what you see. Um,
Yeah, I mean, I would say what you mentioned in terms of the central nervous system effects. I have a whole textbook. Well, it's a digital textbook, but it's called Mental Health and Microglia. And so it's all about the microglia, white blood cells in the brain getting turned on. And, that can cause anxiety, depression, insomnia, brain fog. And it can happen with any virus. COVID happens to cause it a little bit more, but we see it with Lyme, Bartonella, Babesia, Mycoplasma, and then mast cells get triggered. And most people know mast cells release histamine, but they also release chemicals like prostaglandin D2, prostaglandin F2 alpha, leukotrienes. And so ketotifen, which is a compounded medication, it's a great mast cell inhibitor that's used a lot in functional medicine. And then Dr. Theo Harides, who's an MD, PhD, he likes luteolin, which has a great effect on the brain in terms of calming down histamine. So obviously we need a certain amount of histamine for learning and memory. Too much is going to cause brain fog, anxiety, insomnia, and maybe depression. And so the product that you formulated, I know you had two products I saw on your website.
Yep.
Um, Talk to us about the mechanism because I think there's Dan Shin in there.
Mhm.
There's a nitric oxide
Yep.
modulator, beetroot, and then there's
Mhm.
curcumin, which is anti-fibrinolytic, correct?
Yep. Yep. So when I got into the literature to really start looking for new molecular targets for long COVID, um, uh, uh, something that happened that was kind of unique in my career, I didn't find the information I needed and wanted to really start real drug discovery. There were no validated molecular targets yet that were kind of new and needed new drugs developed against them. The science in the long COVID space just isn't mature enough yet for that type of activity. So having my friend that had long COVID and was really looking for answers and really in a bad way, I went back to the literature and said, okay, well, what do we know and where can we go with it? to figure out, maybe there was something we could repurpose or do kind of modification of with an eye towards doing a shorter round of drug development. And I kind of came upon the microclot hypothesis and really kind of went down the rabbit hole of looking at all the data on microclot hypothesis, which I'm a big believer of. I'm a convert to that one. And basically, microclot hypothesis says that COVID spike protein binds to fibrinogen, which is the protein in the blood that's responsible for clot formation for us.
Okay.
That spike protein binds to fibrinogen and causes an unnatural change in conformation of fibrinogen. And that unnatural protein structure now is sticky, and it actually kind of polymerizes into what's called now amyloids of fibrin. So they're these the colloquial name for them is microclots, right? So they're these sticky clots. They bind to a lot of other things like platelets and red blood cells and all kinds of other proteins and small molecules in the bloodstream. And the microclot hypothesis is very attractive and very elegant because it helps to account for a lot of the downstream symptoms through a physiological mechanism, right? So the microclot in for instance, binding to red blood cells impairs oxygen delivery into the tissues. That's where you get a lot of the fatigue issues. They're clots, so they can have disruption of cardiac and respiratory effects. The brain fog is thought to originate at least partially from hypoxia of the brain, from lower oxygen delivery to the brain because the red blood cell permeation into the tissues is impaired because they're bound to these microclots. Microclots also cause platelet activation. So you get platelet hyperactivation that gives you dumping of all the serotonin in the platelets. The platelets, of course, also kick off an immune response. So the microclots are just this really bad actor that do seem to form in people with long COVID. And there's really solid molecular level data in the literature, both where they took like recombinant spike protein and added it to blood samples, and you can see the microclots. And also looking at patient samples from people with long COVID. It's not a clinical test. You can't go to your physician and get this test done, but there's a laboratory test where they can detect these microclots in blood samples from long COVID patients. So it's a really nice physiological pathophysiology mechanism of what's driving long COVID. And I saw that and I said, okay, well, great. And then the investigators, Risa Pretorius and Doug Kell, they actually did a small clinical study with a therapy called triple anticoagulant therapy. And they took about 90 long COVID patients. They were clinically diagnosed with long COVID, so they met the symptom criteria, and they checked them for microclots. They all had microclots, and they treated them with this triple anticoagulant therapy, which is a cocktail of three anticoagulants, right? And they got really impressive results. And it's a small study, but they had like an 80% recovery rate from long COVID. And they double checked on the back end. The people that recovered, they checked them for microclots, and the microclots in their blood were gone. So to me, that's kind of the good molecular level data that I look at when I'm looking at pathophysiology mechanisms. So at that point, I started asking people I knew with long COVID, well, why aren't you guys all taking triple anticoagulant therapy? Like, this is a solved problem. What's the issue? And I kind of got three answers, and it's basically that there's three problems with triple anticoagulant therapy. The first is it's three anticoagulants together, which we really don't do very much because there's kind of a high safety risk for bleeding as a side effect when you put three anticoagulants together. So that's number one. Number two, the physicians were kind of reluctant to prescribe it. I think both because of the safety risk, but then also because there wasn't more data yet justifying using it in long COVID. So the patients couldn't get it, even if they were willing to take the safety risk, because they couldn't get a prescription. And then there's a cost issue because one of the components, apixaban, Eliquis, is quite expensive, and insurance doesn't really want to cover that kind of anticoagulant for long COVID because it's not approved, right? So looking at that situation, what it seemed like to me sitting in the medicinal chemist chair, where we really think about developing therapeutics, is you needed a safer, which means a little bit less potent version of triple anticoagulant therapy that was accessible to people, ideally over the counter, that was inexpensive, right? So I started thinking about that, and it kind of took me back to earlier in my career, in my training. I used to use natural products as the starting point to do drug discovery. So we would take a natural product and be inspired by that mechanism and structure, and then develop new drugs from that. So that was the way kind of was trained, and I kind of learned to do drug discovery. And looking at this situation with triple anticoagulant therapy, I said, well, what if we reverse the process? What if we start with the pharmaceutical drug cocktail that's not ideal, and using the mechanisms of action of the drugs, reverse engineer back to natural ingredients that have the same mechanisms of action, that would be an over-the-counter, safer, less potent version of triple anticoagulant therapy that would be natural, that people could use for long COVID. So I did that work to kind of do that reverse engineering, and custom formulated a product that people could take to help recover from long COVID. And it's got components in it that mimic those mechanisms of action. So the apixaban is a factor 10A inhibitor that gets replaced by curcumin, or organic turmeric, which has curcumin in it. Curcumin's mechanism of action, it's a factor 10A inhibitor. The second component of triple anticoagulant therapy is aspirin, which is a COX-1/2 inhibitor. It's a platelet
White willow bark.
activation inhibitor, right? So I replaced that with white willow bark, right? Because that's the same mechanism. And then the third component in triple anticoagulant therapy is clopidogrel, which is a P2Y1, P2Y12 receptor antagonist. So, and I went to the literature and found that Dan Shen, which is an extract from traditional Chinese medicine, has a couple of components in it, natural products that are the same P2Y1, P2Y12 receptor inhibitors, right? So those are the one-to-one replacements that are in the product. And then it's got some black pepper extract in there that acts to make the turmeric more bioavailable and keep it around, not get it metabolized so fast. And then the last thing I threw in there, because fatigue is kind of one of the hallmark symptoms of long COVID, I threw some beetroot extract in there with the nitrous oxide to help boost tissue oxygenation as people were recovering, to give them a boost and help them recover from that fatigue. So I custom formulated that product that I call CircuGuard, and so far it's been working really well for people recovering from long COVID.
Yeah, so I read some of the testimonials, and people were saying, "Oh, I've tried, multitude of products. My
Yeah,
wife is getting her life back. She's able to
yeah,
participate in life again. My brain fog cleared up within 4, 5, 6 days, which is pretty remarkable." And the other thing, I mean, you touched on this, but with curcumin and the other nutraceutical ingredients, not only do they do the same things as
yeah,
the pharmaceuticals, they have side benefits. So we know curcumin slash turmeric downregulates NF kappa beta, which is a
yep.
master inflammatory switch. So instead of just going after one little thing, it's like a big volume, turning the volume down.
It is, and in its own way, it's kind of great because you've got anti-inflammatory compounds in there, you've got antioxidant compounds in there. So basically, it's helping prop up and support the body recover in a broader way from long COVID. Because the reason triple anticoagulant therapy works, whether it's the pharmaceutical version or the nutraceutical version, is basically you're slowing down coagulation, you're slowing down formation of microclots to help the body clear and deal with the microclots that are already existing. And adding those extra anti-inflammatory, extra antioxidant properties on top of that kind of starts helping the immune system get back into balance. It helps more holistically with the inflammation that's seen in the endothelial lining of the circulatory system, which is one of the other things that the microclots really do.
Do you know? So one thing I've dove into the past year and a half is the endothelial glycocalyx. Do you know if the spike protein targets that or has any effect on that, or is there any data showing that impacts it?
I haven't looked at that aspect in too much depth. That's basically causing the inflammation in the lining of the yeah, I haven't gone down that vein in the literature yet too much, mainly because I've been focused on kind of the mechanisms that let us take direct action. And by trying to deal with the microclots, they seem to be the aggravating factor
Yeah.
for what causes that inflammation. So I haven't looked at that literature.
Yeah, so there's a product we use a lot called Arteriosil. It was developed by a cardiologist. It has a lot of fruit and vegetable extracts, but they've done studies that show it can reduce arterial plaque, and specifically it supports
Mm-hmm.
that endothelial glycocalyx, the protein matrix. And the epigenetic testing we do a lot, there's a genetic locus called 9p21. And we all have it. It's just a matter of what version we have. So 0 to 2G is optimal, 3G is suboptimal, 4G to 6G is poor. And so the 4G to 6G people have a significantly increased risk of damage to the endothelial glycocalyx. We also test for the angiotensin converting enzyme 2 um,
Mm-hmm.
genetic variant. And I know that COVID plays a role in that, correct?
Oh yeah, because the ACE2 receptor is really the kind of anchor point that spike protein binds to, and it's the entry door into cells when COVID infects cells. And there's a there's a lot of ACE2 receptors in the lungs, which is kind of that first point of attack for spike protein and for the virus. But then once you get it, there's ACE2 receptors everywhere in the body, and spike protein just locks onto them. It's how it infects tissues and how it kind of sticks around in the body.
And that's the same mechanism by which African Americans have an increased predisposition to hypertension, correct?
Yes. Yep.
Yeah. And so I know there was a basketball player, I'm not sure what his name was because I don't really follow the NBA, but he voiced concerns and the media kind of jumped on him and said, "Oh, well, he doesn't understand science." I'm like, no, he actually understands a great deal what he's talking about. But at any rate, so what I would say is in terms of the mast cell activation, we deal with that all the time because I work with a lot of people who have mold toxicity, biotoxin issues. And they're the most common activator of mast cell activation. Dr. Theo Herides, and then he was a professor where I got my doctorate, but Dr. Lawrence Afrin. I'm not sure what medical school he's at now, but he's big on using various medications. There's Xolair, which you're probably familiar with more so than I, but that's supposed to inhibit the mast cells. It's an injection, I believe. And then there's the ketotifen. Um, and then low-dose naltrexone is something big in the functional medicine world. Um, and I know Dr. Peter McCullough and Dr. Pierre Croy, they recommend it. I've been taking it. So I had mold toxicity in Lyme myself,
Mm.
but I've been taking it mostly prophylactically since 2010, because it modulates Th1, Th2, and it raises natural killer cells. I literally had someone back when I had a physical office and clinic took this lady from with MS from wheelchair bound to walking
Mm.
almost independently within 6 weeks. And
Wow.
we're talking about, $50 a month. And most MS drugs are, 12, 1500,
Yeah.
maybe 2000 a month. But now I know if you Google, I think it's still up, low-dose naltrexone, and then put PDF after it. There's an ebook written by a combination of pharmacists, MDs, PhDs, and patients, not only with case studies, but going through the molecular mechanisms in terms of recalibrating the opioid receptors on the immune
Right.
cells. And one thing I learned last year as well is that mast cells actually have GABA receptors on them. And that's one reason why tapering off of benzodiazepines is so hard, is because the mast cells flare up.
Oh, I didn't know that. That's actually really interesting.
Yeah. And so I have a colleague, Dr. Christine Schaffner. She created this cream. It's a GABA lotion that you apply to the temples at night. I use it for sleep, but it's bound to chondroitin sulfate. And so that allows it to cross the blood-brain barrier. But she was the person who taught me that, yeah, mast cells have GABA receptors. The benzodiazepines, from all the research I've done, it messes up the sodium potassium pump, it downregulates acetylcholine, which activates the vagus nerve, which activates the
Yep.
parasympathetic nervous system. And then you get the GABA glutamate skewing. So glutamate goes way up, GABA goes down. DHHB, I don't know if you guys study that at all. It's dihydrohinochial B. It's
No.
from the magnolia bark extract. This is a little unrelated to the interview topic, but I take it. There's no addiction potential. Dr. William Seeds, I call him the bow tie doctor. He's always wearing a bow tie, but he's won awards from every major sports organization, NASCAR, NFL, NBA. But he does regenerative and cellular therapies now. He still does some orthopedic surgery, but he tries to, help people heal without the surgery most of the time. And DHHB, it downregulates NF kappa beta in the central nervous system,
Mm.
and it binds to the same receptor as Xanax and the other benzos. So, but without the addiction potential. And so, I'm a big fan of that. It doesn't really make you drowsy; it just kind of relaxes you. Which my colleague, who's a psychiatrist, he said, attention deficit is really a misnomer. It's really an excess of attention. You're paying attention to everything. And if you can calm down the brain, you can, focus in on one stimulus at a time. But sorry, I didn't mean to take over there, but it's kind of
Yeah.
off on a tangent.
No, and I think it further reiterates, what I find really interesting doing what I did with long COVID is, we're not paying as much attention as we probably should be to how a lot of these more natural components, natural extracts, and the molecules in them can really help with some of these physiological issues, with some of these diseases, with some of the symptoms. We it's like we've decided that we've moved on from that as science and medicine, and we're just not going to use those anymore. They don't really work. We need, pharmaceutical drugs that were developed with a specific, scientific process. And I know one of the things I have really focused on and tried to do with long COVID is bring that natural remedy aspect back and give something people that they can access now, that's available, that's accessible, that's affordable. While we wait, it's while we wait to do drug discovery. It's not that we're never going to
Right.
discover new drugs for long COVID. It's we need more data. Like science just needs time to generate enough basic research to do that work. And it used to be in the old days, I do a lot of oncology research. So it used to be in the old days, we would use natural drugs, natural products to tide us over while we're in that period of trying to really discover and optimize drugs for a disease state. And we understood that's just the way it worked. It was you do this until eventually there's a drug. But now it's like science has evolved and forgot where it came from. It's forgotten the
Yeah.
way we used to do things. And that these natural remedies really do work for people and can help people feel better. Are they cures? Are they true therapeutics? In most cases, no, but they can certainly help with symptoms and they can help with people's quality of life and day-to-day function.
Yeah. And the study you mentioned where they did the anticoagulant therapy, what was the treatment period?
They segregated them by how severe the long COVID was. So
Okay.
for mild long COVID, they treated him for 2 to 4 months. For more severe long COVID, they treated him for 4 to 6 months with the pharmaceutical triple anticoagulant therapy.
And then they were able to stop the anticoagulant therapy?
Yeah, in the patients that recovered, basically the long COVID resolved, so they were able to come off the therapy, right? So I think the theory there is, right, spike proteins causing microclots. So you start on a triple anticoagulant therapy, you slow down microclot formation, the body clears the microclots, and obviously the spike protein to cause the microclots has to be coming from somewhere, right? Most people kind of attribute long COVID now to viral reservoirs somewhere in the body. A lot of people will say it's in the GI tract, it's infecting the microbiome. Other people will say, well, it's taking up residence in the brain, it's causing a lot of the neuroinflammation effects. So, but regardless of where, you have to have some kind of viral reservoir because that's what's causing the microclots, right? And I think when you go through triple anticoagulant therapy, as you start bringing that microclot level down, the other systems of the body, in particular the immune system, start actually recovering more and are probably more able to clear the underlying viral infection, which is why at the end you can really come off of triple anticoagulant therapy once the microclots are cleared.
And the other thing is, I haven't looked to see if the COVID virus does this, but most every pathogen I've ever studied produces biofilms to hide from the immune
Yeah.
system. Pathogens obviously are very, very smart. Most people are worried about car accidents and those things are serious, but usually it's something you can't see with the naked eye that's
Yeah.
going to take you out. But biofilm, dentists were the first to discover it.
Mhm.
Pathogens in the oral microbiome hide underneath it. And I have a colleague who she's an MD and she does 10 pass ozone therapy, but she does like half the typical dose of heparin, so 2,500 units. And
Mm.
it breaks up these circulating immune complexes, biofilm, basically.
Mm.
And then that makes the ozone much more effective. And she's able to kill off, these pathogens.
No, that makes sense, and that's great. And I know, like, in Lyme disease, biofilm formation by the bacteria that causes Lyme disease is one of the main mechanisms that for the persistence of the bacterial infection that causes a lot of the chronic Lyme disease issues.
Yeah, absolutely. That and people don't address mycotoxins, and
Hmm.
they're ubiquitous in the environment, and they all do different things, but one common denominator is they all suppress the immune system. Some are class 2B carcinogens, but nephrotoxic, hepatotoxic, negatively impact the GI system. If you look at brain scans of people with MS and people with mold toxicity, you can't distinguish between the two.
Really? Oh, I didn't
Yeah.
know that.
There's white matter lesions. So people will say, "Oh, I have white matter lesions. I have MS." I'm like, I believe that you have white matter lesions. I can see the scan. However, what caused the white matter lesions? And I have one colleague who's in Virginia, actually. I've only spoken with her once, but she had a patient referred to her with a diagnosis of Alzheimer's. She's also trained to evaluate mold toxicity. And something just didn't sit right with her. So she worked her up for mold, did the lab test. Long story short, about 7 months later, she no longer had the label of Alzheimer's. And
Wow.
so if you look at Dr. What's the guy's name? Dale Bredesen, the neurologist who developed the RECODE protocol for resolving, if you want to say curing, Alzheimer's. He talks about mycotoxins, stealth pathogens activating the microglia,
Yep.
inflammatory cytokines. He tests people for that because the tau proteins, they're really a consequence of the disease, but not the cause.
Right.
Those
Yep.
other things are cause. And then we know a gut dysbiosis precedes most neurological diagnoses by 2 decades. And I just
Mm.
saw a colleague post the other day that there's a study showing that people who had COVID have decreased bifidobacteria and fecal
Yeah.
bacterium prosnitzi in the gut.
Yeah, the gut dysbiosis and the changes in the gut microbiome are increasingly being looked at in COVID, and that's kind of one of the driving factors in people thinking that the GI tract is really the source of the viral reservoir for long COVID. There is more and more data that COVID's causing significant issues in the GI tract. I know there was a paper last year where it's showing that COVID viral infection in the GI tract can actually change the ability to absorb serotonin, right? Which gets into those CNS issues, right? From a mental health point of view as well.
Yeah, and then you have that gut brain axis. For every one signal the brain sends, the gut sends eight back. So fire in the gut, fire in the brain. Um, so yeah, I think, working on the gut microbiome, prebiotics, I think the prebiotics are probably more important than the probiotics, providing a fuel substrate. Um, and that can only help the brain health and then the systemic inflammation as well. So the other product you have, I think was called Oxy Boost. Is that right?
Yep. And so that was one that I formulated. I had a lot of people that really wanted something for just the fatigue alone. Maybe they had MCAS and they were worried about taking a lot of supplements. So the OxyBoost is really just a really high quality formulation of the organic beetroot. to help people with the fatigue and help with tissue oxygenation. And that's another one where I've had a lot of people tell me, even when they just take that alone, it really helps with the fatigue because you're getting such good free oxygenation of the tissues that all of a sudden they can move again, right? The fatigue's not so bad, and they're getting that nice boost. Even though that one doesn't address the microclots, but a lot of people wanted that just to take by itself for the fatigue.
Absolutely. What's something that you know today that you wish you would have known at the beginning of your career?
That I wish I had known beginning of my career. In general, or when it comes to long COVID, I guess is the question.
Both. About that.
Both. Um, I I I wish I had have known better, um, had a better understanding of kind of in science how even in science we go through trends, right? And things go in favor and out of favor. And I wish I had a better feel for that, because I think there's some things that have gone out of favor that are really important things we're missing now that we should really try and be bringing back to do, because at the there's a lot of work to be done in science on everything. And I've always kind of had an interest in orphan diseases, in some of these chronic disease states that get less attention. And I really wish that NIH and some of the other agencies would make more resources available, because there's large patient populations out there suffering from a lot of these things, and there's just not enough resources collectively going into them to help really solve problems and make a difference for people.
Yeah, absolutely. Last question, just out of curiosity. Are you the only professor on doctor in your department who studies nutraceuticals and their impact on disease states?
Yeah, pretty much everybody else, because and that was, going down this route of doing nutraceutical was a huge departure from anything I've ever done, and I'm really the only one in my department that's doing these things, and really what it came out of was long COVID is a big problem. People are really suffering from it, and in the job that I have, I know that in order to develop new drugs for long COVID, which is a new disease, right? It's really a 10 to 15 year drug discovery and development cycle, right? There are no new pharmaceuticals coming for long COVID anytime soon. So it was one of those, I kind of got to the point where I had to make a choice. Was I could move on and do something else and just not do anything in long COVID. But I didn't want to do that because people really needed help. So I kind of went down this route that is less typical for an academic, but it's still one I think that is helpful for people, gives them some tools to try and help themselves and to recover. And it gives me the opportunity to actually help people now instead of in 10 to 15 years.
Yeah, I think a lot of people forget that it takes 17 years on average to go from bench to bedside. And
Yeah.
so a lot of times, I mean, we have studies from the 90s or even 80s that have not been implemented yet, that you got overlooked for whatever reason. I mean, just basic science stuff. I mean, if you look at something like curcumin, turmeric, I mean, the mechanisms, the studies on it are robust, and people just assume because they don't hear about it that it doesn't exist. And I say, just go to PubMed, type it in. There's a lot resveratrol, same thing, omega-3 fatty acids. So yeah, there's a lot out there. Because I remember when I was in school, Lavazza prescription omega-3s came out.
Yep.
And at that time, this was like 2008, they were charging insurance like $250 for a month's supply. And omega-3s don't work. And then we came out with our, oh, it works. And I'm like, okay, I'm starting to catch on here, how the system works.
There's a lot of things that we can be doing for people, and there's a lot of information people can be using to help themselves. There's a lot of products that are not necessarily a pharmaceutical. A lot of people are starting to have issues with some pharmaceuticals, particularly ones that have a lot of side effects. You know, a lot of people are interested in these more natural remedies that are safer and a lot of times have a better profile than traditional pharmaceuticals. And there's nothing wrong with them. We treat them like there's something wrong with them when really if we could just give people good information, use the information that's in the literature, there's a lot that we can do to help people using nutraceuticals and other natural remedies.
Absolutely. Well, thank goodness for people like you going off your nonconformist path like I did. So keep up the great work. Thanks for developing the products. I know you're helping a lot of people. And I think it really holds a lot of water when you see someone in academia. So a lot of times they'll say, oh, well, you're not in academia, so you don't really understand research. So I'm like, no, I understand research.
Yeah,
So
science is science. The
yeah,
experiments work the same way. You know, it's just people have to be open-minded and ask questions and accept the answers in an unbiased way. And sometimes it's also about asking the right questions, right? This really started for me when I went back to the literature, and instead of saying, "What drug can I develop?" I asked the question of, what can I do with the existing scientific data to really help people? That's a significantly different question than we normally ask.
absolutely. Well, thank you so much. Keep up the great work. And it was great meeting you.
Thank you. Thank you for having me.